Thank you, and thank you for the opportunity to speak. And normally, I'm used to speaking at medical conferences, so it's a little bit intimidating to be in this room after hearing all of you speak, but I'll do my best. How do I, there we go. So this talk is going to be on, we have collaborators at University of Texas, you heard from Ennio earlier, and we've been collaborating with them, working on translational aspects of their technology to diseases. So I look at things from a little bit of a different perspective, from the opposite end of the spectrum, thinking what do they have and how can we use it for some of our clinical problems. So a lot of my talk is going to be a little bit of a step back and explaining what situations we're dealing with, and then I'm open to any suggestions anyone has for ideas for how we could possibly translate some of all the wonderful ideas I've heard here to perhaps address some of these diseases in ways we haven't thought of yet. Myself, I'm an orthopedic surgeon. I do spine surgery, and then I also do a lot of laboratory research at the hospital. So my life spent sort of in two places. 2 days a week I'm in the laboratory doing tissue culture work, and the rest of the time I'm either in clinic or in the operating room. And basically, most of what I do is dealing with end-stage, I guess what we call phenotypes here, the end-stage results of degenerative diseases of the spine, be it the joint in the knees, the hips, or the spinal column, or dealing with the results of trauma, which cause musculoskeletal injury, or debilitating inflammatory arthropathies of the hands. And this is an example of a hip with bone-on-bone arthritis. And if we go back, and the other thing then is dealing with spinal cord trauma, which is both mechanically destabilizing and also obliterates the spinal canal and the neural elements. And so the one aspect is reconstructing things biomechanically and getting the bones to heal. And although as of right now we're not yet there, the ultimate hope someday is to be able to attenuate to some degree or perhaps even reverse neurologic injury, because the spinal cord and nerve roots run through this area which was obliterated by the fracture of the car accident. And this is again an MRI showing the trauma of the accident and the bone retropulsed into the spinal canal, obliterating the neural elements. And unfortunately, right now in this day and age, our main ability for these patients is to reconstruct the spinal column to provide them with a stable foundation on which to sit and do weight transfers from, say, wheelchair to chair. And it's fairly abysmal right now in terms of any neurologic regeneration, but the hope is someday to be able to do more than just mechanical support for this type of an injury. And this is the other extreme, would be a herniated disc or sciatica, which then presses on the neural elements. And the main thing we're treating with this is the pain, which we'll get into later, is multifactorial. It's both from the mechanical compression on the nerve root as well as the chemical insult that is caused by the inflammatory cascade of these tissues touching the neural elements in the spinal canal. And so currently our interventions are basically biomechanical and structural. If someone has a spinal cord trauma, we're able to decompress the neural elements, and then we reconstruct the column by basically interposing fusion cages and reconstructing the anterior and posterior columns of the spine. And so for that spinal cord trauma patient, we were able to remove all the bone from the spinal canal, the bone that was broken, rebuilt it with an expandable cage that's filled with bone graft, and then reconstruct the posterior column. So we still have a long way to go. And there's an example of someone with degenerative scoliosis for whom you then do, and left untreated, this curve will cause progressive curvature, which will impede respiratory function and cardiac function. And currently what we're able to do is reconstruct the curvature as best as we can and then stabilize it in situ with a long fusion construct. And then for osteoarthritis, we have a total hip replacement. And although right now I would call these treatments crude because we're basically acting at the end stage of the disease, and to be fair to orthopedics, I mean, total hip's probably the most successful operation in the history of mankind. I mean, total hip replacement, coronary artery bypass, and total knee replacement are the most successful operations in human history. So some of our treatments are good, but we don't want to rest on that. We want to do better. And the ultimate goal for arthritis, for instance, would be not to get to this point. So all these diseases have in common that they're end-stage musculoskeletal pathology. And all of our treatments have in common that we're basically operating once the damage has occurred. So we're pretty far downstream. And ideally, we want to get further upstream and intervene before these things become apparent, either through injury or in the office in physiology. And a lot of the disease, I'm going to now focus more towards the spine because that's what I'm probably most qualified to talk about, is basically through our lifestyles. You know, we started off more or less on all fours, and now we're back to a sitting and recumbent position over the past 100 years. And the issue is when we stand, it's probably a very nice position for our backs. Sitting actually causes the most mechanical stress on the intervertebral disc in your back. And so just by happenstance of our social evolution, we basically are now have assumed a predominant position in our lifestyles, which is the worst possible thing to do for your spinal column. And the impact of this is huge. Spinal disease and musculoskeletal disease is the leading cause of disability in terms of lost days from work, and it costs hundreds of billions of dollars annually, both in medical care costs as well as lost productivity of the economy. And an example of FDA has 510K approvals for studies for when someone files a 510K, they're going to bring to market in the future, they hope, a mechanical device to treat these diseases. And this just shows between 1990 and 2003, there's an average of 90 510K applications per year for technology to address the end stages of musculoskeletal pathology. None of these technologies are going to address upstream, which is really what we want to do. And you look at emerging technologies from the Millennium Research Group, all these technologies are for addressing end-stage spinal diseases. And this is a number of procedures forecast just over the next 2 years, look how much it's going to grow. And so what is the spinal column? Well, the spinal column basically acts primarily to transmit load through your body as you walk around. You have your spinal column on the bones, and then you have an intervertebral disc, which is a shock absorber. The intervertebral disc is composed of a nucleus pulposus, which is basically a hydrated hydrogel of proteoglycans analogous to the solid matrix of cartilage, and is surrounded by annulus fibrosus, which is predominantly collagen tissue, which acts as a tension band. So as you bear weight, you constrict, press down, water is dissipated through this matrix through frictional drag, and compressive energy is dissipated through that energy, and annulus fibrosus surrounds the nucleus pulposus and constrains its ability to swell outwards. And what we know with aging, all of us have this ubiquitous degeneration on our backs. This is sections through tissue and MRI, where you go from a nice hydrated disc, and as we age, our disc collapses down and becomes degenerated. Now, we all have different stages of degeneration, but this is a fairly ubiquitous process. And that's significant because Scott Bowden in 1992, he looked at people who had MRIs of their back who had no pain whatsoever. So these are people who had MRIs for some various reason. And what he found was in asymptomatic people with no back pain, between 60 and 80, 93% of them has some evidence of degeneration in their back. And that's significant because, so if somebody walks into your emergency room, walks into your office and has this MRI and back pain, that doesn't mean this is causing the back pain. Because we already know if you're 80, 90% of people have this. And so it's not just enough to be able to look at the phenotype, as it were, the picture of a degenerated disc when someone has back pain and blame it on the disc. That could just be a irrelevant finding that's no more significant than the patient having gray hair or wrinkles on their face, because our collagen ages internally just the same as it ages externally. So what's emerging now is an idea that pain may be a distinct process from physiologic aging, because we now know once we're in our 80s, almost all of us have degenerated disc with no back pain. So why does the person who has debilitating pain that keeps them out of work, what is different about their degenerative process than people without pain? And we don't know the answer yet, but the hypothesis right now is that when you have an injury to the disc, a traumatic injury, be it a fracture of the end plate or a laceration, something happens in the body's attempt to repair that. And when the inflammatory cells go there, they secrete nerve growth factor, which causes the sinovertebral nerves that pathologically innervate the disc secrete chemical mediators, which then causes a massive inflammatory cascade and a pathologic degeneration of the disc, which is incredibly painful. And so there's some sort of difference between a pathologic degeneration and normal degeneration, which is different, and we don't yet know these relationships, but we need to figure them out. We want to really do a good job for these patients, a better understanding this pathologic chemical milieu that occurs in that setting, and then intervene in it early before your disc collapses and is gone, and you have two vertebral bodies sitting on one another, because it's much harder to reconstruct that after the fact. So what data supports all this? Well, some work was done in Jefferson and Philadelphia looked at gene expression in traumatic disc injuries and found significant upregulation in an animal model after a traumatic laceration of MMPs, fibronectin, and interleukin-1 relative to control. So what about a human model? Well, we took people who went to the operating room for surgery with a degenerated disc and compared their discs to people who had their discs removed for another reason. Say somebody who had a car accident, spine trauma, had to have the disc removed for a fusion procedure, scoliosis. And what we found was, even though these discs were both the same MRI grade degeneration, they had very different cytokine profiles. So there's something different in the chemical milieu of these patients for painful versus non-painful discs that are degenerated. And then an animal model that I worked with some collaborators at in Maryland on for a null mouse who, unfortunately, the patent lawyer sort of beat me up before I came, so I can't say what the knockout is, but this is the wild type mouse. You knock out one transcription factor, and this is what you do to the spine. You get a degenerated disc with a scoliosis phenotype,